But surprisingly, the perceived obligation to present an image of strength is not always associated with negative outcomes. In fact, sometimes that's protective, depending on the sample and the situation in which I'm researching African American women. And I say surprisingly because many people think this concept of strength or the strong Black woman role might be maladaptive. However, women have told us, and we're finding in our research, that being strong is affiliated with this concept of resilience. So no matter the hardships people go through, if they find ways to remain strong and they continue to persevere, then that is beneficial. What we are doing research on now is looking at the combination of those constructs. So it may be that if someone is obligated to be strong, but they have no one to talk to about their stressor, so they're high in strength and high in emotional suppression, that might be maladaptive.
Welcome to the Stress Puzzle, where we explore the latest in stress science and consider how the science may translate to our daily lives or where we might have missing pieces for actually making that connection. I'm your host, Ryan Brown, and I'm a social health psychologist working with the Stress Measurement Network, which is a team funded by the National Institute on Aging and includes internationally recognized stress experts from UCSF, UCLA, and Yale. I'm so happy to be able to share today's interview with Dr. Cheryl Woods Giscombé. We focused on the Superwoman Schema framework that she's developed and how it relates to health disparities among Black women. Dr. Giscombé has investigated stress and coping among Black women in particular, and the ways that stress science has missed important nuances of how Black women cope with stress. Dr. Giscombé's work was referenced on a previous episode with Dr. Tanae Lewis, who emphasized the importance of Dr. Giscombé's paper on whose stress is making me sick. So I also recommend going back to be sure you've heard that episode on stressors occurring beyond the individual and associations with ambulatory blood pressure. Between these two episodes, we really start to see more clearly the physiological and psychological cost of caring. Dr. Cheryl Woods Giscombé is the Melissa and Harry Levine Family Distinguished Term Professor, Senior Associate Dean, and Chief Wellness Officer at the University of North Carolina at Chapel Hill School of Nursing, with a secondary faculty appointment as a professor in the Department of Social Medicine at the UNC School of Medicine. Dr. Woods Giscombé's research focuses on biopsychosocial factors that influence health and health disparities through psychological stress and coping pathways. She is a fellow of the American Academy of Nursing, the National Academy of Medicine, the Academy of Behavioral Medicine Research, and the Mind and Life Institute. Dr. Woods Giscombé also recently authored a book titled The Black Woman's Guide to Coping with Stress: Mindfulness and Self-Compassion Skills to Create a Life of Joy and Well-Being, which we'll discuss in our conversation today. Welcome to the Stress Puzzle, Dr. Woods Giscombé. I'm so excited to speak with you today.
Thank you so much. I'm really excited to talk with you as well.
You've massively impacted the field of stress science by introducing Superwoman Schema as a framework to understand health disparities among African American women. Could you describe what Superwoman Schema is, and any research, writing, theories, or sociocultural or historical context that contributed to you developing this conceptual framework?
Thank you so much for your question and your kind words. So I define myself broadly as a stress and coping researcher, and I study or investigate the effects of stress on health conditions, health behaviors, and psychophysiological mechanisms that connect stress to health. And so for many years, as an undergraduate student, and maybe even before then, I was just really curious about why certain groups had higher rates of adverse chronic health conditions compared to others. So for example, African Americans, I learned in school, like many of us did, that African Americans have higher rates of hypertension and blood pressure, obesity, and other types of chronic illness like that. But I remember the first time I learned that we weren't given any rationale. And so I was really curious about what caused that and wanted to understand that. So in undergraduate school, I majored in psychology and was mentored by some really great researchers who studied stress and coping and cardiovascular disease and psychophysiology and biological psychology, and trying to understand how stress links to those conditions related to metabolic conditions like diabetes, cardiovascular conditions like heart disease, and other chronic illnesses. And then I went to graduate school and studied with my advisor. Her name was Dr. Marcy Lobel, and she's still a very excellent researcher. And she studied how stress influenced low birth weight, preterm delivery, and infant mortality, as well as other maternal morbidity related to the birthing experience. And so I learned a great deal from her about how to conceptualize stress, how to ask questions about stress to understand its impact. But at the same time, I was learning that Black women had twice the rate of adverse birth outcomes, at least twice the rate compared to white women, so more than twice the rate of low birth weight, infant mortality, and preterm delivery. But there weren't a lot of great explanations for that. It was hypothesized that things like lack of insurance or lower access to medical care or later engagement with healthcare during pregnancy or things like education may have influenced those disproportionately high rates of adverse birth outcomes. But the research was showing that those socioeconomic factors did not fully explain the differences. And so through my work with Marcy, I started to explore stress in Black women, and through reading the literature, became really fascinated by the fact that we were not comprehensively defining stress in Black women. We were using generic ways to measure stress, and so we weren't really capturing the fullness of the ways that stress might impact health. And we weren't including things like gender-related stress, we weren't including things like race-related stress, and we weren't including some of the nuances of how Black women cope with stress. And so with Marcy's mentoring and mentoring other professors, I started to ask questions and worked on this concept that you named called the Superwoman Schema in your question. And so through qualitative research with Black women from various socioeconomic backgrounds and educational levels, I was able to develop the Superwoman Schema framework. And so Superwoman Schema is a conceptual framework, and the characteristics of Superwoman Schema include 5 domains we gleaned from our research. And the 5 domains are a perceived obligation to present an image of strength, a perceived obligation to suppress emotions, motivation to succeed despite limited resources, resistance of help from others or dependence of others, and prioritization of caregiving over self-care. So those are the 5 characteristics. But the conceptual framework also involves content on where this came from. So how did Black women come to identify with those 5 characteristics? And those are related to historical factors such as their historical experiences of oppression in their individual lives, in their family lives, but also multi-generational levels of that influence how their mothers or their families communicated to them about coping with stress, how they saw their mothers cope with stress, and also how they were stereotypically perceived by others and how they wanted to overcome those stereotypes. And women also shared with us in our research that those 5 characteristics of Superwoman Schema were both factors that help them be strong and resilient, but also things that help them deal with stress while also serving as barriers or limitations to their well-being. And so, for lack of a better term, Superwoman Schema is a double-edged sword.
Right. And thanks for taking us through the multi-dimensional nature of Superwoman Schema. And I'd love it if you could talk us through the double-edged sword that you're mentioning here of being a superwoman for health. And how does this idea contribute to both resilience on one hand and more chronic health issues on the other hand?
Thank you. Great question. So once we developed the framework, I was able to work with a team of researchers to develop a scale to measure Superwoman Schema. So we have a 35-item scale. It's called the Giscombé Superwoman Schema Questionnaire. And with that scale, which is psychometrically, valid and sound, we spent many years developing it. We're able to test some of these hypotheses and some of the things that we learned from our research participants in qualitative research. And so the research has shown that for the most part, largely, Superwoman Schema characteristics are associated with things such as lower physical activity, so more sedentary activity, emotional eating. For some women, depressive symptoms are higher. The higher their Superwoman Schema scores are, perceived stress is higher. But also, when we look at each dimension of Superwoman Schema, not all of them have negative associations with these health conditions or health behaviors. So the one that is the most consistently associated with adverse outcomes is that perceived obligation to prioritize caregiving over self-care. So
Mm-hmm.
that helping category. The other one that is often consistently associated with adverse outcomes is the emotional suppression. But surprisingly, the perceived obligation to present an image of strength is not always associated with negative outcomes. In fact, sometimes that's protective, depending on the sample and the situation in which I'm researching African American women. And I say surprisingly because many people think this concept of strength or the strong Black woman role might be maladaptive. However, women have told us, and we're finding in our research, that being strong is affiliated with this concept of resilience. So no matter the hardships people go through, if they find ways to remain strong and they continue to persevere, then that is beneficial. What we are doing research on now is looking at the combination of those constructs. So it may be that if someone is obligated to be strong, but they have no one to talk to about their stressor, so they're high in strength and high in emotional suppression, that might be maladaptive. Or they're high in emotional suppression and high in caring for others, then that may be maladaptive. So, what the scale does and what this framework does is help us have more nuanced understanding of the stress and coping experiences of Black women, and then how we can develop and target interventions, because we don't want to throw the baby away with the bathwater, meaning we don't want to tell
Right.
women not to be strong. We don't even want to tell women not to care for others, because that is a really important component of people's identity. But how can they be strong and care for themselves while also finding ways to care for others? So it's really a great way to help women become more aware of the dynamics of their stress and coping experiences in the context of their families and in the context of society. And then they can make decisions about how to navigate healthy changes in their lifestyle and their coping strategies.
Right. And in different contexts, I think a lot about the cost of care work. And so I really appreciate how Superwoman Schema is bringing to light another angle of how we can be thinking about the impact and perceptions of care work. So I really appreciate that you're also thinking about those intersections of the different dimensions within there. And since you did so much qualitative work, I'm curious if there are any quotes from participants that stand out to you from your work on Superwoman Schema.
Oh, yes. There are some quotes. Some are longer than others, but one in particular is from a participant who was reflecting on the strength of her grandmother. And she talked about how my grandmother always cared for our family. My grandmother always put us first. My grandmother was there for everyone. She was really strong. But as the person was talking, they said, but my grandmother also had diabetes, and my grandmother also had heart disease, and my grandmother also was always very
Mhm.
tired. And then that person reflected to say, was that really strength? Is that really something that I should model myself after? And so what that reflects is re-examining schemas, for lack of a better term, of how a woman should be or how a mother should be, and reflecting and dissecting on what is it that I need to keep and what is it that I need to question and maybe go about doing things differently. Another quote that one of our participants shared is they use the common quote, what doesn't kill you makes you stronger. Meaning, if you keep being resilient and you keep pushing through challenges, what doesn't kill you makes you stronger. But then that person also reflected by saying, but what doesn't kill you can also make you sick.
Oof.
So,
Mhm.
so it may not kill you, but you can get sick and have chronic functional issues from always putting others first or from not prioritizing your own well being. And so that happened a lot during our qualitative interviews, where the discussion, and these were focus groups. So the discussion with women, the discussions we had helped them to think out loud. And so it was somewhat of a therapeutic session as well, because they were supporting each other through discourse and understanding how the characteristics of Superwoman schema impacted their lives.
Right. And I bet, groups are starting to feel the sort of cosmic, massive history and intergenerational, all of that.
You're right on target, I think, by, just being aware of, number one, people don't get a chance to talk much about their feelings,
Right.
or they don't really get a lot of time to reflect on, why do I do what I do, or why do I
Mm-hmm.
respond the way I respond? So I love the fact that these focus groups that we conducted, and also when women actually complete the Superwoman Schema Scale, they really have an opportunity to reflect. And it's going to have a different impact on each individual differently. And that's the beauty of it. And it's the beauty of the interventions that we're working on that are not one size fits all, but they help women determine what and how they want to make changes in their lives to be healthier.
Actually empowering versus, many of the quote unquote self-care options that are presented to us.
Yes. And they're strengths based. So
Yes.
meaning that we're helping them to see how does this is actually adaptive for me in some situations. Let me keep that and let me kind of review and observe what's not adaptive.
Yeah, and I love that you've brought up the different contexts a couple of times here. You were mentioning it earlier, the obligation to manifest strength. And I'm just curious how you think about Superwoman schema in different contexts, whether that's family life or the workplace, broader communities.
That's such a great question because people do operate differently and it's helpful to operate differently depending on where they are. So, of course, in the work setting, it may be adaptive to suppress emotions. It may be adaptive to resist help from others. Women have shared with us that, and this relates to one of the quotes that they've shared too, where their mothers told them, don't let anyone take your niceness for a weakness, or when you let people help you, don't let them take advantage of you. And so these are some of the reasons that women say they endorse some of these characteristics because they didn't want to be vulnerable. They didn't want people to perceive them as weak or perceive them as not being able to stand up for themselves in situations. And so in the work setting, some of these characteristics may be highly adaptive, but if they don't have a place to let their hair down, so to speak, where they can accept help, where they can talk to others about their true feelings, where they can allow others to care for them, then that can be a challenge. And so it really speaks to the challenges that women and Black women in particular face in certain settings where there may be the one of only, and they feel like they have to represent, and this is what they shared with us, represent women, represent Black women because of opportunities they've been given. And so that is a heavy burden to carry. And that's one of the contributors to some of these Superwoman schema characteristics.
And man, as you're talking about these quotes, I really want to emphasize or encourage any listeners who are new to thinking about Superwoman schema or any of these issues to go in and check out. We'll have it linked in the show notes for this episode to go in and read some of those quotes because they really exemplify and really ground this framework for you. So I really urge you to go and check out those specific quotes. And then,
Thank you.
oh, yeah, absolutely. Are there any elements of Superwoman schema that you think would apply to women of other racial or ethnic minority groups? Or is each piece so inherently tied to the specific experience, forms of oppression, and responsibility within systems of oppression that have been forced on African American women?
I definitely think that other women who are not African American, can identify with Superwoman schema. From the first time I presented this research to diverse groups of women and even men, actually, they shared how the framework and the 5 characteristics resonate with them as well. Superwoman schema is like other stress and coping phenomena in that stress is inherent, right? It's part of our lived experiences, and the social and gender related contextual factors that influence how we experience stress and how we cope with it are universal across different cultures. What makes the difference is the exposures, right? So certain groups are exposed to a broader variety of stressors or a higher level of stressors depending on the societies in which they live. So as human beings, we all experience stress. Women are all exposed in some way or form to gender related stressors. And that could be sexism, but it also could be more mundane, everyday gender related stressors, like the roles that many women take on, not all women, but many women take on in their households or as mothers or as caregivers in their family. So you have those gender related stressors. So that's another type that they're exposed to. Men have their own form of gender related stressors. And then if you have people of color or people who live in a society where they have been historically marginalized or oppressed, then they may also have race related stressors, including but not limited to racism and discrimination. And so when there's a broader variety of stressors and there's a highly likelihood of experiencing stress in various situations, then that activates the coping response. And so that means there may be more times that Black women take on these Superwoman schema characteristics to navigate the complexity of the stressors that they experience. So hopefully that makes sense in terms of those interactions, once again, how the intersecting identities and how that makes life and the stress and coping experience a little bit more complex.
Yeah, and that's a perfect segue into the sort of next section that I was thinking about chatting with you about. Earlier, when you were mentioning that we haven't adequately defined stress among Black women specifically, you've been working towards that with the measure that you mentioned earlier. I'm just curious if you see any potential or need in any particular domain to refine our measurement of stress related to the experience of African American women.
Yes, I think that Superwoman Schema is a great start, just to be honest. And I'll give some examples. I would say in the 1990s and early 2000s, there's an increase in the number of research studies trying to understand disparities in health. So, as I mentioned before, adverse birth outcomes, hypertension, obesity, diabetes, lupus, other autoimmune conditions, and things that African American women may have higher rates of. And the early research was equating in many ways African American women with low income women. And so you would see titles like High Rates of Obesity in Low Income African American Women, or Understanding the Disparities in Cardiovascular Disease in Black Women, but then the sample was all low income. And so, yes, that's a very important thing to study. And we need to understand the socioeconomic factors that influence adverse health conditions. And we want to do things in terms of policy to improve the well being for people who have social economic challenges. And an interesting finding in research related to many of these outcomes, including adverse birth outcomes, is the disparity was even higher among higher
Right.
economic status Black women.
Mhm.
So if you compare college educated Black women to college educated white women, the disparity was the same or even greater, meaning that college educated Black women were not protected as we would assume through being educated or through having higher income careers. And so if we think stress is just related to low socioeconomic status, or we think health risks are just related to that, we're missing, once again, the nuanced experiences of people. And so the Superwoman Schema, when we did our research, the beginning, the foundational research with focus groups, we intentionally included women across socioeconomic status. A lot of research of Black women did not include women who were college educated, and definitely not women who had advanced or terminal degrees. So we intentionally included women who lived in public housing projects. We intentionally included women who did not complete high school or college. We intentionally completed women with college educations, and we intentionally had a group of women who had advanced degrees, lawyers, people with PhDs, etc. The themes of Superwoman Schema were the same across all of those groups. How they expressed their experiences might be a little bit different, but they really weren't that different. And so what that says is there's more to the health risk of African Americans than being low income or lower educated or not having health insurance. There's something about the Black experience that crosses socioeconomic strata. And unless we pay attention by doing more complex research and include diverse groups of African Americans, we're not going to see that. And we are going to be identifying the wrong thing as the cause, and then developing interventions that are not going to make the biggest difference that they could potentially make. So in all research, my perspective is that is looking at the impact of stress on a condition. I think researchers should really measure stress in a multidimensional way, including people's self-reported stress, the physiological markers of stress, but also at least stress that's related to race and gender experiences, and then these nuances like Superwoman Schema that look at the complexity of how people respond to stress and try to cope with stress. I know that was a long answer, but
No, it's
if we
perfect.
really want to make a difference, we have to be more comprehensive in our research.
Absolutely. And I think to a certain extent, it's figuring out from folks I was working with at various times throughout my postdoc, figuring out how to model these questions too, right? When we want to look at intersections of different identities, it can get complicated on the modeling side. I'm glad that we're in a place where the need is so clear to really be looking at a more granular level at the different experiences at each of these intersections of identity, and we'll get the models to catch up.
And I can give you an example from our intervention research. My research team and I, we did a study several years ago called We Can Prevent Diabetes. And so this was with African American men and women who had prediabetes. And we were trying to test a mindfulness based diabetes risk reduction intervention that included education about physical activity and nutrition. But we also hypothesized that stress was a mechanism influencing people's prediabetes status and their diabetes risk. So when we implemented the mindfulness based diabetes risk reduction intervention, we conducted interviews and focus groups after the study, and we isolated some of the data that we had with women to try to find out, their perspectives about the mindfulness intervention. And they shared that they thought mindfulness was very helpful with stress reduction and it was culturally relevant. But then they said, but I didn't have time to practice. There are challenges with mindfulness. Even though they liked mindfulness and even though they knew it worked, their challenges with practicing something that could benefit their stress and their health were related to Superwoman Schema. So they talked about, I feel like this is a luxury for me to be able to do this when I have so many people to help. Or my children need me to take them to these practices, or my parents need me to take them to these appointments. By the time I finish doing all that, I don't have time for myself, or I feel guilty prioritizing myself. So the challenges that they had with taking that mindfulness training to the next step were related to Superwoman Schema. So in our current study, the Harmony study, we have further tailored this intervention to reduce cardiometabolic risk by including physical activity, diet, mindfulness, but the mindfulness is tailored to the characteristics of Superwoman Schema. So women, when they're learning the principles of mindfulness, the pillars of mindfulness, and applying it in their practice and in their lives, they're thinking about how it relates to how they cope with stress and how they relate to these 5 characteristics of Superwoman Schema. And so far, women have anecdotally shared with us how beneficial that is for them. But we'll be finishing that study next year, and we'll see if we help women a little bit better to integrate healthy eating and physical activity and self-care into their lives through not only mindfulness, but through better understanding the nuances of stress and Superwoman Schema in their lives.
That's so great. And I can't wait to follow along with the results of that study. And, this really brings me to something that I deeply admire about your work, and especially your commitment to reduce this gap from research to practice and actually be affecting people's lives. The whole purpose of this podcast and a lot of my beliefs are around how much we need to be having folks who are doing the research actively be disseminating, the reliable research beyond our tiny little journal audiences. And so I imagine you probably feel incredibly motivated to address these historical wrongs through dissemination efforts. And you're able to really provide this evidence-based guidance around stress and stress-related coping strategies. So I'm curious if you can tell us about your new book and how you think about reducing the research to practice gap.
Oh, thank you so much. Yes, we know that it takes at least 10 years and oftentimes more for research that's published in articles to really have a broader impact on the public. And so I've had a long-term goal of writing a book, but I never really, put plans fully into action. I knew I would want to do that later in my career. But during COVID, when many of us were doing research presentations online, through virtual types of conferences and things, I received a follow-up email from a conference presentation from a publisher, the New Harbinger Publishing Company. And they asked me, would I be willing to consider making my research available to the broader audience through writing a book about my research on Superwoman Schema and mindfulness. And so I was excited to have that invitation, and it was really exciting to be able to transform the research into chapters and have the audience be the women that we hope to help. And the most challenging part was changing my scientific writing into writing.
Oh, I'm sure.
But the publishing company was wonderfully supportive every single step of the way. And so it's really a great honor and a privilege to be able to share the book in women's groups and women's organizations, families hear about groups buying the book, and then they invite me to come and speak about it. I actually have a couple of sessions coming up at the beginning of the year. And so it's really great to be able to share the research that way.
That's wonderful. And that book is titled The Black Woman's Guide to Coping with Stress, Mindfulness, and Self-Compassion Skills to Create a Life of Joy and Well-Being. And it's linked in the show notes for today. And, we were talking about interventions a moment ago with mindfulness interventions. And I'm curious if you can talk to us about any stress reduction techniques, including mindfulness, that you might feel particularly enthusiastic about, whether at the individual or system level.
Oh, absolutely. And I'm so glad you asked that, because it does require multi-level interventions for us to address health disparities. We focus our research, my team and I, mostly on the individual level, but we also do work on the policy level. And so, of course, on the individual level, mindfulness, loving kindness, self compassion for the purpose of helping people to become more aware so they have greater wisdom in the moments of stress or in the seasons of stress, because we know they're not usually just moments. There are often seasons we're going through. And then when we get through one season, there's another season, but it's a different situation. And so, helping individuals to be more wise about their own personal needs and aware of how they need to navigate. And that changes with our development. So, how we coped last year may need to be different than how we do it next year. And that's why these one size fit all approaches don't work as well. But mindfulness is something that adapts with people as they adapt and change, and they take the time to practice mindfulness with that present moment awareness and in the service of compassion for self and others, and in the service of increasing self-awareness. Then you always can have an opportunity to respond to situations with awareness, because the stressors, let's face it, they don't stop coming. In the meantime, we can also work on policy level interventions, work-based interventions, because most of us spend most of our time at work. And so that's why I'm a big fan of workplace wellness interventions, because people spend the majority of their time at work. Most people do. And I'm really excited and motivated by the leadership of our U.S. Surgeon General, who has developed a workplace well-being framework. And I'm really excited about the opportunities I've had to lead wellness initiatives at my university, in my School of Nursing. And I've been doing that for several years. And now that work has transitioned to a formal office of well-being, in which I implement interventions with faculty, staff, and students, but also implement well-being interventions with health professionals, so nurses and other healthcare professionals, but also at the university level, where we're seeing so much stress among undergraduate and graduate students and faculty, is extending there to help create well-being initiatives. So it's helping us create new policies in the workplace settings to help people, because we're not at home most of the time, we're at work most of the time. And that can translate then to higher level policies in healthcare. So that's really exciting, but I don't think it's a one or the other. I think we need to focus on system level change while we're also helping individuals, because the system level changes take a lot longer. And we don't want people waiting for system level changes when they can also find ways individually to be healthier and have a better quality of life.
Absolutely. I'm right there with you on the absolute need for the multi-level interventions. And it's wonderful to hear how expansive your sphere of influence is becoming, and all of the different domains that you're being able to support health across these institutions. So congratulations. And that's just wonderful to hear.
Thank you.
Is there a particular finding from your career that feels the most meaningful to you, either because of the importance of the results or anything in the research process itself?
I think one of the things that really helped our team be enthusiastic was how in our pilot studies, our pilot and feasibility studies of integrating mindfulness in a culturally relevant way with African American adults, how it had an impact in a very small sample size, statistically significant impacts on hemoglobin A1C and BMI and people's self-reported stress. So that gave us the fuel we needed to continue to develop larger research studies. So this really matters. It really makes a difference. So those findings excite us. And of course, the findings with the Superwoman Schema scale, that when others are using my scale across the country doing research, and they're not only continuing to find that the scale is psychometrically sound in different populations of Black women, different samples of Black women, but in using both self-reported outcomes as well as objective markers, so biomarkers of stress and objective measures of health outcomes, the relationships are still being shown that Superwoman Schema is something we need to address to help women be healthier. So it's just exciting every time I see a colleague publish a new article about Superwoman Schema and its effects on sleep, or its effects on lupus activity, or its effects on cardiovascular risk and allostatic load, or telomere length. I mean, there's so many examples now. And so the years of working hard to develop the framework and the scale have really paid off, that we have something that is reliable and valid, and the results are becoming less deniable in terms of this being something we really need to pay attention to help women be well and have a higher quality of life.
Absolutely. It must be, like you said, such a joy to be able to see all of the different findings and domains and different researchers who are taking on this framework that you put forward. And, I just wanted to say thank you again so much for joining us today for this episode of The Stress Puzzle. And it was such a pleasure to learn from you, Dr. Woods Giscombé.
Thank you so much. It was a pleasure to talk with you. I appreciate your questions and your time. Thank you.
Thanks for tuning in to this episode of The Stress Puzzle. We'd love to hear your thoughts and feedback on any issues we've covered today. You can email us at stresspuzzlepod@gmail.com, and you can also send requests for topics or guests for future episodes. The best way you can support the show is by leaving 5-star reviews wherever you listen to our podcast and sharing with your friends or your collaborators. And until next time, we're wishing you good stress and opportunities for rest.